Thank you, David, for inviting me to participate in this session that I also very much enjoy. So I want to present to you an interesting case that's a near miss. It's appropriately named, but this is an interesting case of left ventricular remodeling. I have to put my disclosure slide and just mention specific to two of the drugs that I mentioned in the case presentation, I have received honorarium from Servier as well as Novartis. So the patient history, we have a 61-year-old male with no prior history that presents with a 6-month history of worsening dyspnea, productive cough, and orthopnea. He comes to the emergency room, and as you can see, he's notably quite hypertensive. This man barely sees a physician. He was on no medications prior to this. His saturations are low, but maintained on 2 liters of nasal prong oxygen. His JVP is increased 6 centimeters above the sternal angle. He has decreased breath sounds to the bases bilaterally. Otherwise, there is some bilateral peripheral edema. So his ECG, as you can see here, does demonstrate large voltages. There is a poor airway progression, and we can see a potential strain in the context of the suggestion of left ventricular hypertrophy. And he was notably quite hypertensive on presentation. His chest X-ray does show a vascular redistribution and a dilated cardiac silhouette, all consistent with heart failure. This gentleman was admitted to the medicine service because of the shortness of breath. Some clinician had questioned possible pulmonary embolism. Although it doesn't show well here, the findings of the CT scan are a right atrial appendage thrombus, as well as bilateral pleural effusions and congestive hepatopathy. The patient gets an echocardiogram done as part of the admission, and I'll just start to show you the images here. So you can see here that the LV function is quite reduced. It's about 25 to 30%. He's mildly dilated with an LVID of 6 centimeters. In terms of, the other thing is too that, and it's a little bit difficult to appreciate, but in terms of if it's segmental or global, there does seem to be global LV dysfunction. Perhaps the septum is a little more involved. And there's an abnormal thickness too. We're measuring by conventional criteria about 15 and 15 on the septum and posterior wall. And he was quite hypertensive. And although these images don't show it well, the overall echocardiogram was interpreted as moderate mitral regurgitation. And when we look at diastolic function quickly, we can see that that he has very abnormal tissue Doppler velocities of roughly 4 and 5. Respectively, we can see a big E, small a, some pulmonary vein flow, systolic with blunting. So in the context of contemporary diastolic guidelines, reduced LV function, E to A above 2, this is grade 3 diastolic dysfunction. So the course in hospital, he is admitted and diuresed. I'm not sure why that's blackened out, but he's anticoagulated for the right atrial thrombus. He started on medical therapy that includes NOAC, an ACE inhibitor, perindopril, bisoprolol, amlodipine, presumably for the hypertension, and furosemide. He's discharged with a plan for outpatient medical titration and referral to a heart failure clinic. So 3 months later, this patient finds himself readmitted with heart failure. A repeat echocardiogram is done, and it's changed from his initial presentation. We can see that there's now at least 2 LV thrombus localized at the apex. The LV function, despite 3 months of apparent compliant medical therapy, has reduced slightly to an ejection fraction by Simpsons of 20%. The degree of mitral regurgitation seems somewhat increased. This was a non-contrast study, but you can see multiple thrombi towards the apex. Once again, he has abnormal diastolic function with a big E and small a and reduced tissue Doppler velocities. The patient from this admission is actually treated and discharged, but he does have outpatient right and left heart catheterization performed. And the noticeable findings are that he has a reduced cardiac index. I neglected to mention that on his initial echocardiogram, he did have some evidence of pulmonary hypertension with an echo-derived PA pressure of 60 to 70 millimeters of mercury. 3 months later, now by right heart catheterization, the pulmonary pressure is 34 on 12 with a mean of 23. His wedge is up only a little bit at 14. And both by FIC as well as thermodilution, his cardiac index is around 2 liters. He undergoes an outpatient cardiac left-sided catheterization that demonstrates proximal occlusion of the LAD, not felt to be chronic. There's some collateral flow from his circumflex. He does not receive any intervention. So as an outpatient, the patient, as part of our heart failure guidelines, is switched to ARNI, sacubitril and valsartan. His ACE inhibitor, perindopril, was discontinued, and he was started on the ARNI, which is the name for the class of drug, angiotensin receptor neprilysin inhibitor. And he was titrated. There are 3 doses of this drug, for those of you not familiar, and it was titrated to a maximum dose over 3 months. Now, in keeping with guidelines, he had an echocardiogram repeated after another 3 months for consideration of prophylactic ICD. So just following the heart failure guidelines algorithm, after several months, he was switched to the ARNI, and 3 months were given to see if there was any improvement in his LV function, with the thought being that his EF was still lower than 35%, then we would consider putting in an ICD. He didn't have a wide enough QRS to consider for CRT. And recall also that after 3 months of basic therapy, his EF actually went down slightly to 20%, and now he's been placed on high-dose neprilysin inhibition. Okay, so this becomes really interesting. So the echocardiogram now looks like this, and I'm seeing the patient in the clinic. The echo hasn't been reported, but I fire it up on the computer, and this looks like the wrong patient. So I called the lab and I confirmed that it's the right patient. You can see now that the LV function looks like it's normalized or very close to normal. The ultimate ejection fraction is 50 to 55%. But recall that I had said he had concentric LVH initially with echo-derived measurements of 15 and 15 on the septum and posterior wall. Now he has a septum that measures 22. The posterior wall on echo is still measuring 15. And you can appreciate as we go down that 3 months prior to this, we can see that there is asymmetric septal hypertrophy, and previously 3 months ago, where he had a bilateral or biventricular or 2 thrombi in his LV, now there is just a trace or a footprint of a very small apical wall motion abnormality with dissolution of LV thrombus. The degree of MR has also gone down. His EF is 50 to 55%, and even his diastolic filling has now reverted to stage 1. Where he was particularly, or previously he was grade 3, and now he's grade 1. So, in terms of hunkering down the diagnosis, a cardiac MRI is also done. And the cardiac MRI does confirm asymmetric septal hypertrophy with a septum measuring 22 millimeters and the lateral wall measuring 12 millimeters. And there's late gadolinium enhancement with 2 different patterns. So on slide B, there is subendocardial enhancement of the infralateral and apical septal walls, and in stage C, there is patchy confluent mid-myocardial enhancement of the basal to mid-septum. So I spoke at length with the radiologists who were interpreting and described the clinical history. So this is in keeping with hypertrophic cardiomyopathy. However, there are some findings also suggestive of concurrent LAD scar. So it's an interesting case in the sense that now in heart failure, which is my clinical practice, we see a lot more volumetric remodeling, even though the data on ARNIs is still yet to be published. But this is a case also of structural, if not remodeling, but unmasking of a pathology that was evident all along that we did not appreciate. So the question is, did this patient have burnt out hypertrophic cardiomyopathy, or was this LAD territory scar that reverted? Either way, it's an interesting observation that the medical therapy reverted both potential entities. Just a quick note about burnt-out hypertrophic cardiomyopathy. So there was an excellent session yesterday by one of our panelists, and we can see that and roughly 5% of patients with hypertrophic cardiomyopathy will develop advanced LV dysfunction. This is associated with adverse LV remodeling, cavity dilatation, and wall thinning due to extensive myocardial fibrosis. So the proof for this comes from LGE demonstrated on MRI, as well as pathologic assessment of the ex-transplanted hearts that this observation is made. And usually when people have burnt-out hypertrophic cardiomyopathy, the clinical deterioration is very rapid, and oftentimes the patient needs to be considered for cardiac transplantation. So the learning points in this very interesting case, so if it was between coronary disease and HCM, which was the actual initial one that reverted it, background of hypertrophic cardiomyopathy. So the learning points is that abnormally thickened ventricles need close delineation. So in our patient, it was an abnormal echo at the beginning. It was an abnormal ECG. He did have poor airway progression. Cath was not done on initial presentation for unclear reasons, but his septum and posterior wall each measured 15 millimeters each. His tissue Doppler velocities were markedly abnormal, and this is somewhat out of keeping with standard hypertensive heart disease, particularly the tissue Doppler velocities I had showed you. Once again, just on the copy of HFpEF, so we have a patient, and you can say I've gone from HFrEF to HFpEF, big deal. It was a success. We got the F above 50 to 55%. But once again, I think the point that was driven home yesterday in the heart failure session was that we need to look beyond the ejection fraction, as this patient's diagnosis of hypertrophic cardiomyopathy was unmasked until follow-up. Has certain other considerations regarding genetic testing, family screening, need for prophylactic ICD, et cetera. So just two acknowledgments, two of my cardiology fellows who had helped with preparation and submission to an ultimate successful manuscript were Basil Alsabeek and Olu Cheyenne from London. So thank you very much.